Good morning. Thank you for the opportunity to present. I have no disclosures. There has been an increase in the use of minimally invasive techniques for the repair of newborn congenital anomalies. This has featured increased exposure to minimally invasive surgery for pediatric surgical fellows and trainees across the board. However, previous data has lacked the statistical power to assess surgical performance across a series of metrics. Hospitals and providers would benefit from performance benchmarks, including length of stay and 30-day postoperative complications. The objective of this study was to examine length of stay and complications following minimally invasive repair of newborn congenital anomalies, using the ACS NSQIP pediatric database from 2013 through 2018. We selected 10 congenital anomalies of infancy with well-described minimally invasive repair techniques, as well as sufficient quantities of repairs within the NSQIP database. The most numerous repair of pyloric stenosis was examined on its own in a group entitled Simple Repairs. 4 anomalies, congenital lung lesion, mediastinal cyst or mass, congenital malrotation, and anorectal malformation, were categorized as complex group 1, due to these anomalies requiring more complex pediatric surgical care and longer length of stay related to the diagnosis. The remaining 5 anomalies, Hirschsprung disease, congenital diaphragmatic hernia, tracheoesophageal fistula, intestinal atresia, and hepatobiliary anomalies, were categorized as complex group 2 due to these anomalies requiring more complex multidisciplinary care and extended length of stay related to their diagnosis and other comorbidities. Outcomes assessed included postoperative length of stay, unplanned reoperation within 30 days, unplanned readmission within 30 days, postoperative surgical complications across various organ systems, and finally, a composite outcome which included any 30-day complication. Our statistical analysis included multivariable negative binomial regression for postoperative length of stay and multivariable logistic regression for postop complications. Our models were adjusted for preoperative predictors related to patient demography, comorbidity, organ-specific risk factors, and admission-related factors. Within our cohort, there were 8,326 total minimally invasive repairs from 2013 through 2018. Patient counts according to each anomaly are shown on the right. In this figure, we present the median postoperative length of stay and interquartile ranges for each congenital anomaly. Tracheoesophageal fistula had the longest postoperative length of stay of 20 days, and laparoscopic pyloromyotomy had the shortest postoperative length of stay of 1 day. Factors associated with increased length of stay in each of the 3 groups included increasing calendar year, inter-hospital transfer status, severe or life-threatening ASA class, and cardiac, neurologic, and systemic risk factors. The overall complication rate was 8.5%, including 5.2% for the simple group, 12.2% for complex group 1, and 22.1% for complex group 2. Cardiac risk factors were predictive of complications in all 3 groups, and a series of factors were significant predictors in 2 groups. The overall reoperation rate was 2.5%, including 1% for simple group, 4% for complex group 1, and 8% for complex group 2. The reoperation rate ranged from the lowest rate of 2.5% for mediastinal mass to the highest rate of 20% for tracheoesophageal fistula. Risk factors for 30-day reoperation varied by group. The overall readmission rate was 4%, including 3% in the simple group, 6% for complex group 1, and 9% for complex group 2. The readmission rate ranged from the lowest rate of 3% for congenital diaphragmatic hernia to the highest rate of 15% for hepatobiliary anomalies. Risk factors for 30-day readmission varied by group. In conclusion, this study reports national estimates for postoperative length of stay and complications after minimally invasive surgery for 10 congenital anomalies, which can be utilized for evaluating surgical outcomes and hospital benchmarking. Future studies will compare and attempt to adjust for patient disease factors in comparing surgical outcomes for minimally invasive surgery versus open repair for congenital anomalies. Thank you for your attention and the opportunity to present, and I welcome any follow-up questions.